Thank you again. The next speaker is Dr. Benjamin Smith. He's the Director of Endoscopy at the Brigham and Women's Faulkner Hospital, and also an Assistant Professor of Medicine at Harvard Medical School. His topic today will be diarrhea. Tough topic to discuss in 30 minutes, but he's up to the task. Welcome, Dr. Smith.
Thank you very much. I'm on it. I want to thank Dr. Mutinga, Dr. Singh, and the other course organizers for asking me back to cover acute and chronic diarrhea. And unfortunately, I have no commercial or faculty disclosures. So today, our ambitious goal is to discuss both acute and chronic diarrhea in under 30 minutes. And to do that, I'm going to focus on the essentials that you need to know to take care of your patients and to take the boards, and sprinkle in some new developments. I'm going to start by defining acute, chronic, and persistent diarrhea. And then I'm going to launch into the approach to acute diarrhea. What is the differential diagnosis? What's the best diagnostic approach? When is it appropriate just to watch and support your patient? But when do you need to do additional testing? What should that include? And when do you need to treat? And what should that treatment include? Then for the second half, we're going to talk about chronic diarrhea, a large, unwieldy subject. And I have found it's very helpful to think mechanistically. Is this chronic diarrhea watery? And if it's watery, is it secretory or osmotic? Or is it inflammatory diarrhea with mucus and blood and pain? Or is it fatty diarrhea with floating stools, bloatorous, and large volume? I find this mechanistic thinking helps to guide my initial and diagnostic evaluation, my differential organization, and follow-up testing. So we're going to start with acute diarrhea. The objective definition is an excessive stool weight more than 200 grams per day, but I think most of us think in terms of the subjective definition, which is an excessive frequency of defecation, more than 3 stools a day generally, and stools of less than normal form and consistency. Acute diarrhea resolves within 4 weeks. Chronic diarrhea lasts greater than 4 weeks, and persistent diarrhea is that which lasts between 2 and 4 weeks. Normally, 10 liters, a large amount of fluid, enters the jejunum daily. 2 liters approximately is taken in as food and drink, and the other 8 liters comes from your salivary, gastric, biliary, pancreatic, and intestinal secretions. 9 of those 10 liters is resorbed, and just 1 liter of liquid fecal contents enters the colon daily, and 900 of that is excreted. Only 80 is resorbed, only 80 to 100 mil are excreted daily. This is an exquisitely sensitive system. So if you have just 50 to 60 mil of increased daily fecal water, you'll have loosening of your stools. If you have 100 mil, you'll have diarrhea. So many disorders can disrupt intestinal fluid and electrolyte absorption by at least this amount. So acute diarrhea is a frequent event with an extensive differential diagnosis as a result. So it's helpful to divide your acute diarrhea patients into 2 classes. Do they have infectious diarrhea, which is the most common, or do they have non-infectious? And if they have infectious acute diarrhea, the viruses are the most common cause, with norovirus making up the majority, and then rotavirus and some others. The bacteria may cause acute diarrhea. Think of the food poisoning bacteria, and I'll come back to them in a few minutes, and C. diff in your patients in the hospital or on antibiotics. And then a distant third are your parasites and protozoa. The other category are non-infectious causes of acute diarrhea. Medications. The 1,600-page pharmacopoeia tome, Goodman and Gilman, references the entire book under diarrhea. Think of all your medications, over-the-counter, prescription, and then also think consumption of poorly absorbed sugars, the sugar alcohols like sorbitol, mannitol, Splenda. Tube feedings can cause acute diarrhea. Ischemic colitis, interestingly, causes acute diarrhea. And fecal impaction can masquerade and cause a paradoxical diarrhea around an impaction. So the majority of cases of acute diarrhea are mild, self-limited, and need no further diagnostic evaluation. So when do you need to do additional testing? If your patient has bloody diarrhea, or if they have profuse diarrhea, they're getting dehydrated, it's been going on more than 2 days, they're having more than 6 unformed stools in a 24-hour period, so they're sick. Or if they have severe abdominal pain and they're over age 50, the differential starts to include some ominous things like tumors and ischemic colitis if they have a high temperature, or if they're immunocompromised or elderly. You need to do some additional testing. And the first thing you do is you test for fecal leukocytes with either a right stain or fecal lactoferrin assay, and you test for occult blood. If the stool has both blood and leukocytes, you have what's known as colloquially as dysentery. And this supports a bacterial etiology for their acute diarrhea. And you should know the top four. The way Campylobacter and Salmonella are the most common, followed by E. coli 0157H7, one of the enterohemorrhagic or EHEC infections, and Shigella. The exception is your patient who develops acute diarrhea while they're in hospital, or if they've been on antibiotics or chemotherapy in the past 2 weeks, in which testing for C. difficile toxin has a higher yield than testing for fecal leukocytes. So if your patient is not severely ill and their stool does not have blood or leukocytes in it, it's very appropriate just to treat symptomatically and support them for several days. You're likely dealing with a virus more than 3/4 of the time, and about 3/4 of the time it's a norovirus. Think also rotavirus. You could also have a bacteria elaborating a preformed toxin, which does not cause blood or leukocytes. And you should know the top three. They are Staph aureus, Bacillus cereus or B. cereus, and Clostridia perfringens, not Clostridia difficile. And if there's no blood or leukocytes, that stool culture is not very high yield. It's only positive about under 6% of the time. The situation changes if your patient has bloody diarrhea and they're sick. Then the stool culture becomes high yield. It's positive almost 90% of the time. And you need to check a stool culture if you have a food handler with bloody diarrhea, because you don't want them handling food if they have an infection. In your patients with inflammatory bowel disease, you need to distinguish a flare, which requires, for example, steroids, versus an infection, which requires antibiotics. If you order a routine stool culture, you'll get testing for the top three of four common sources. You'll get Campylobacter, Salmonella, and Shigella results. But you need to notify the lab if you suspect E. coli 0157H7, for example, a common source outbreak from a restaurant chain, or if you suspect Yersinia, which presents like appendicitis with acute right lower quadrant pain, but with bloody diarrhea, or Ehrmonis, if you have severe diarrhea in someone who's been spending a lot of time in the water. You only need one specimen because these bacteria are shed continuously. Remember, though, to check for C. diff if someone's been on antibiotics or received chemotherapy within the preceding 2 weeks, or they developed their diarrhea in the hospital. Available recently are GI pathogen panels, and some can check for, I saw, up to 22 pathogens, bacterial, protozoal, viral, within an hour. So very impressive. You should only check for ova and parasites selectively. For example, if you're asked, your patient develops diarrhea in the hospital, should you check for ova and parasites? The answer is no. You should check if they've had diarrhea now for more than 2 weeks, or if they've been part of a community waterborne outbreak that you're aware of, if they've been swimming in untreated water like streams or rivers, or if they've traveled to areas like Russia or Nepal where Giardia and Cryptosporidia are endemic, or if they're members of high-risk groups that may be immunocompromised or could be exposed more frequently to Giardia or entamoeba. You need to get 3 specimens for ova and parasites on 3 consecutive days, because these are only shed intermittently. So who needs endoscopy? Well, it can be helpful if your patient has bloody diarrhea while you're waiting for your stool results. It can distinguish inflammatory bowel disease versus an infectious diarrhea. Biopsies in inflammatory bowel disease will show lymphocytes, chronic inflammation, whereas those in acute infection will show neutrophils. If you suspect ischemic colitis, you'll see rectal sparing because the rectum has a dual blood supply, and then you'll see inflammation just upstream starting. You can see the pseudomembranes of C. diff. In immunocompromised or other high-risk patients, you can look for CMV. But when we enter a colon that's inflamed, we'll limit ourselves to a flexible sigmoidoscopy because we do not want to push through an inflamed colon and risk perforation. So supportive therapy takes advantage of the fact that even with severe acute diarrhea, the glucose-sodium cotransporter of the small bowel remains intact. So you can give the World Health Organization oral rehydration solution, which contains a mix of sugars and salts, or you can make a homemade solution in your kitchen by adding sugar, salt, and baking soda to a liter of water. There are also rice-based oral solutions. Remember that fluids for sweat replacement, the commercial products like Gatorade, Powerade, and Propel, are not as replenishing as the World Health Organization, but they're good for mild cases of dehydration from acute diarrhea. But you can also just give diluted fruit juice and some saltines and get similar results. Remember also, you need to modify your patient's diet. Tell them to avoid lactose for 6 weeks because the lactase brush border is injured by acute diarrhea caused by viruses, for example, and may not recover for 6 weeks, in which case, if you introduce lactose or they do so inadvertently, they'll be calling you with diarrhea again. Avoid foods with high fat content because that stimulates motility, and give boiled starches like pasta. You can also return to the brat diet, bananas, rice, applesauce, and toast. It provides needed calories, sugars, and salts. It's very helpful. So you also want to make sure that your patient is not taking dietary sugars like Splenda, aspartame, et cetera. Review their medications and try to stop or substitute for those which are temporarily associated with the onset of diarrhea. Assess them for fecal impaction and treat it because that can cause a paradoxical acute diarrhea, and adjust their tube feeds if they're receiving them to dilute, decrease the rate, or add fiber if necessary. Now, it's very appropriate to give antidiarrheal agents such as loperamide, brand Imodium, or diphenoxylate atropine, brand Lamodal, if your patient does not have bloody stools, and if their fever is low grade, say less than 100.5 or so. Also think about Pepto-Bismol. It can be very, very helpful for nausea and vomiting associated with acute viral gastroenteritis, for example. Kaopectate improves the consistency of stools. It's available over the counter, and I often forget it. And racecatril is a prescription medication that's available now that reduces the secretion of water and electrolytes. I have not used it. I've not found it necessary, but it can be helpful. So we restrict the use of empiric antibiotics to a subgroup of patients. If they're immunocompetent but really ill, if they have fever, bloody diarrhea, and they're getting dehydrated with more than 8 stools per day and symptoms for more than a week, then you're considering antibiotics. For example, they're hospitalized because of this. If they're immunocompromised because of AIDS, malignancy, or transplant, and usually we use a quinolone, ciprofloxacin, levofloxacin, for 3 to 5 days. The alternative is azithromycin or erythromycin. And this can be very helpful, for example, with Campylobacter, where we're seeing higher rates of resistance. So you can check your local resistance pattern to help guide your empiric therapy. And again, you're going to be giving metronidazole or vancomycin if your patient has C. diff or suspected C. diff. So the role of probiotics has been mixed. It's been shown helpful in several meta-analyses for travelers' diarrhea. For example, the commensal yeast Saccharomyces boulardii is helpful if you're traveling to North Africa or Turkey. You can also use a lactobacillus or acidophilus. For infectious diarrhea, the data is mixed. If you give 10 billion lactobacillus, for example, you may shorten the course by a day. The role of probiotics in antibiotic-associated diarrhea is uncertain. We need more study. So let's talk about 3 causes of acute diarrhea that are important. Campylobacter, very common, as I said, that and salmonella, the most common. It usually results from eating contaminated poultry that's undercooked. It may run a relapsing course over many weeks, and you can treat it with a quinolone, but check your resistance patterns. You may need azithromycin or erythromycin. Notable complications of Campylobacter. Patients can develop a reactive arthritis or Reiter syndrome with arthritis, urethritis, and uveitis. About 1% of patients with Campylobacter. It begins usually about 1 to 2 weeks after the diarrhea and may last for several months with a waxing and waning course. Did you know that Campylobacter infection is responsible for about 25% of cases of Guillain-Barré syndrome with ascending paralysis? The symptoms begin within 3 months of diarrhea onset, and by that time, the patient is usually culture negative, but their serology will likely still be positive. Unfortunately, our antibiotics do not help prevent these complications. And then moving on to the enterohemorrhagic E. coli, the most common being E. coli 015787, usually results from undercooked meat ingestion and may affect the young and the old badly. Normally, patients will present with watery diarrhea, and then note that it develops blood within 24 hours. And atypical for these invasive infections, there's usually no fever. And these EHEC infections may elaborate 2 proteins, a shigatoxin and an intimin, which is an adhesin protein, which allows the bacteria to adhere tightly to the intestine and do their thing. Now, enterohemorrhagic E. coli with both proteins can create and cause the potentially lethal hemolytic uremic syndrome, which manifests with acute renal failure, hemolytic anemia, and thrombocytopenia. You need to ask if you suspect this, and remember, If you suspect E. coli 0157H7 or one of these EHEC infections, do not give antibiotics because that increases the rate of Shiga toxin elaboration and increases the risk of hemolytic uremic syndrome. So lastly, Cryptosporidium is an intracellular protein parasite. We've seen increased incidence in patients using pools and water parks. It's usually transmitted by sick kids, and it can survive in chlorinated water for 10 days. You need hyperchlorination to kill it. And patients will present with diarrhea, abdominal cramping, nausea, vomiting that can last for weeks. It can be attenuated, the course, with nitazoxanide. So if we turn to now chronic diarrhea, this is an enormous subject that affects 5% of our population annually. It can be caused by a myriad of disorder, and there's no optimum evaluation strategy because the differential differs depending on where you live. But most of the guidelines are based on expert opinion. So today I'm going to try to help you with my opinions. I think it's very helpful to think of the major categories of chronic diarrhea in this country. There are 5 of them. The first is irritable bowel syndrome. The second are the inflammatory bowel diseases, including ulcerative colitis and Crohn's, but also the microscopic colitis, collagenous colitis, and lymphocytic colitis. The third category, malabsorptive syndromes, usually lactose intolerance or celiac disease. And then there are the fourth group, all those medications, herbal, prescription, others. And then chronic infections, less common except in the immunocompromised, and you may have a bacteria or a parasite. Then I find it very helpful to categorize the diarrhea. Is the chronic diarrhea watery? And if it's watery, does it sound like it's osmotic, otherwise known as malabsorptive, or is it secretory watery diarrhea? Or is the diarrhea inflammatory with passage of mucus and pus and blood? Or is it fatty, floating, and malodorous? Unfortunately, because life is never simple, you may have several mechanisms coexisting in your chronic diarrhea. So the hallmark of watery osmotic diarrhea is that it stops once you stop ingesting the osmotically active osm. There's a large osmotic gap of greater than 125 milliosms per kilogram. And you can calculate that by taking a sample of stool, sending it to your lab to calculate the sodium and potassium in that sample of stool, multiplying by 2 to account for the anions, and subtracting from 290, which is the normal osmolarity of stool. And if that gap is greater than 125, you're dealing with ingestion of an osmotically active solute, like magnesium, which causes the obligate retention of water in your intestinal lumen, even as the sodium and potassium absorption remains normal in the small bowel, and you get that large osmotic gap between 290 and what you have in your particular stool sample. So exogenous causes of osmotic diarrhea, or things you take in, the most common are the antacids containing magnesium, like Mylanta and Maalox, or magnesium supplements. Many laxatives, including polyethylene glycol containing magnesium citrate. Also, sugar substitutes, like those found in sugarless candies or gum, such as sorbitol, mannitol, Splenda, and lactulose, and the non-absorbable fats like olestra. Endogenous causes, those within the person, include congenital lactose intolerance, or those acquired, like lactose intolerance after an infection, pancreatic insufficiency, which leads to undigested products of digestion, which exert an osmotic pull, and celiac disease, where you've digested the food, but you can't absorb it. Now, watery secretory diarrhea, the hallmark is that it persists when your patient fasts, and it continues overnight. There's large volume watery diarrhea with a small osmotic gap, less than 50. And the exogenous causes are medications like the stimulant laxatives, but also prostaglandins like misoprostol, theophylline, and colchicine. Also remember, dietary secretagogues like alcohol, caffeine, and colas can cause chronic diarrhea. Endogenous causes are conditions that cause bile acid malabsorption. Remember, your bile acids are produced by your liver, spill onto your food to digest the fat, and then are resorbed in your small intestine to be reclaimed and recirculated. But if there's a condition that allows those bile acids to make it to the colon, they will cause a watery secretory diarrhea by stimulating secretion in the colon. So if you have Crohn's ileitis, you've removed small bowel, if you have bacterial overgrowth deconjugating your bile acids, or if you have a cholecystectomy, so you're spilling bile all the time, you can get a chronic bile acid-induced diarrhea. Also keep in mind those hormone-producing tumors, which are rare. So another word on bile acid diarrhea, it can affect up to 50% of patients who have diarrhea predominant irritable bowel syndrome. It can also affect over more than 10% of patients who've had their gallbladder removed for weeks to months. You can treat it with bile acid sequestrants. Cholesterol is, I think, more palatable than cholestyramine. You can also give cholesevelam. Potential side effects include bloating and flatulence. You also have to remember not to give these bile acid sequestrants within 2 hours of other meds, or they will bind those meds. So now the second category, inflammatory diarrhea, presents with mucoid, bloody stool, and often pain from these invasive bacteria or protozoa or parasites. There's blood and leukocytes in the stool. You can also now in many labs order a fecal calprotectin, which is zinc and calcium binding protein released by neutrophils and monocytes in inflammatory conditions, and you can distinguish inflammatory from non-inflammatory chronic diarrhea by measuring it. Now, the most common causes are chronic infections like C. diff, also tuberculosis and Yersinia, invasive parasites like amoeba and strongyloides, inflammatory bowel disease like Crohn's and ulcerative colitis, also radiation and chemotherapy can do this, and colonic ischemia. Your third category is the fatty diarrhea, and you can see oil droplets in stool and test for them with a Sudan stain. You could, if you have the nerve, order the 72-hour stool collection, and you'll elicit bad reactions from the staff on the floor. You need to have more than 7 grams of fat excreted per day with a 100-gram fat diet. You could also have mercy and order a stool acid steatocrit in many labs, and they separate the lipid component from stool with a centrifuge and measure it, and it's very accurate. Causes of fatty diarrhea include pancreatic insufficiency, Crohn's disease, and short bowel syndrome. So you've depleted your pool of bile acids. So now you have undigested fat. Bacterial overgrowth, like with small intestinal bacterial overgrowth, deconjugates the bile and makes it less effective. So your history is very helpful in categorizing your stool as watery, bloody, and oily. And then you can use factors which you can review here in your current and past history to prioritize your differential. On physical exam, you're looking at the degree of fluid and nutritional depletion. You can also look for extraintestinal manifestations of Crohn's disease like mouth ulcers and skin rashes. You can check for evidence of tumors. And I also do a rectal exam to see if I have a fecal impaction or decreased sphincter tone. So I have chronic diarrhea it's actually fecal incontinence and not chronic diarrhea. So you should get a CBC with differential to check for anemia and also eosinophilia, a parasitic infection, and then other tests for signs of malabsorption, thyroid function tests for hyperthyroidism. I would also strongly consider iron studies looking for bleeding and other tests for malabsorption, such as B12 level, folate, and protime. I also always get a sprue serology and an IgA level to help interpret it because celiac disease remains underdiagnosed. So you should check your stool for bacteria, also fecal leukocytes. I check for C. diff if there's any antibiotic or chemo exposure. And I will get 3 stool samples for ova and parasites and an ELISA for Giardia antigen. Usually you need a colonoscopy, especially if your patient has iron deficiency anemia, or if they're under age 50 or over age 50, you want to check for Crohn's disease, which can be isolated to the small bowel. You want to check their entire colon for tumors. And you also, if it's normal, biopsy to check for lymphocytic and collagenous colitis. I also find upper endoscopy helpful in most circumstances to check for celiac disease or the much less common Whipple's disorder. So if you're still stumped, I think back, all right, have I missed lactose intolerance? Do they have fecal incontinence? And I'm thinking this is chronic diarrhea, and I go through those medications with a fine-tooth comb. I'll get then stool cultures for the much less common Eromonas and Plesiomonas. If my patient has spent any time in the water, I'll check stools for parasites, and I'll get a breath test for bacterial overgrowth. If I haven't calculated the osmotic gap, I'll do that. I'll also, if it looks like watery osmotic diarrhea, get a laxative screen, because this can check for inadvertent or surreptitious laxative use. And if the pH is less than 5.3, that indicates there's a carbohydrate in their stool. If it's secretory watery diarrhea, then I'll check for those rare tumors with serologies for VIPoma, gastrinoma, glucagonoma, and thyroid tumors as mastocytosis. And I'll get imaging to look for pancreatic tumors and lymphoma and tuberculosis. In difficult cases of inflammatory or fatty diarrhea, if I think it's inflammatory, I'll then get MR enterography to look for subtle cases of Crohn's disease. And if it seems fatty, I'll get a stool for Sudan stain, or I'll get pancreatic imaging to look for the substrate for fat malabsorption, such as chronic pancreatitis. You can measure enzymes in stool, but it'll only be abnormal if you have a really disabled pancreas. And I'll get a breath test for overgrowth of bacteria, or even give a course of antibiotics and see if it helps. All right. So therapeutic options include the opiates, which we've mentioned, Lomotil and Imodium, which are very helpful, a trial of antimicrobial therapy. The bile acid binding resins can be very helpful, and octreotide for severe cases, which is given 100 micrograms 3 times a day. So in summary, acute diarrhea is led in the differential by infections, usually viruses. 90% require no further evaluation. You should get stool for fecal leukocytes in blood if your patient is sick. And we only give antibiotics selectively, usually a quinolone. And you want to avoid antibiotics with E. coli 015787. With chronic diarrhea, you have a broad differential, and I find it very helpful to categorize that diarrhea as watery and either secretory or osmotic, inflammatory or fatty. Always keep in mind the concept of fecal incontinence masquerading as chronic diarrhea, and freely give your supportive measures, rehydration, and antidiarrheal agents. Thank you.